Guess we can go ahead and get started. Good afternoon. Thank you for rejoining us, whether you're online in person, for this panel titled, What Actions Can Researchers and HTA Practitioners Take to Improve Equity in HTA? My name is Ebere Onokwa. I'm a professor in the Department of Practice, Sciences, and Health Outcomes Research at the University of Maryland School of Pharmacy. So in this panel, we're building on what we heard in the morning session, particularly in the late morning session with regards to updates from the IVI Health Equity Initiative. And in this particular session, our panel members will be discussing practical approaches and innovative priority actions that we can take to bring change to our HTA methods, to the data that we use for generating these findings, as well as to how we communicate results from HTA. Now, I'm sure if I was to take a show of hands, whether online or digital, there would be significant variation in how everyone is involved with HTA. For some of you, you are involved in directly generating results using HTA methods. Others may be primarily involved in communicating these results or using these results. However you're involved with HTA, how we leverage HTA methods to improve health equity could impact your work. So very pleased to have you here today, and particularly for this session. I hope that you leave today's session with practical ideas for implementing this in your work. And as Jennifer said, take it to your next meeting. Before I introduce our panel members, I just want to offer a couple of logistics for our session. I will provide an opportunity for our panel members to offer introductory remarks. We'll move into a moderated Q&A session that will last about 20 minutes, after which we will advance to the audience Q&A. Now, for those who are online, you are welcome at any point during this session to add your questions into the chat. When we get to the audience Q&A, we will bring those questions live for discussion and hope to bring as many as we can. With that, it's my distinct pleasure to welcome our esteemed panel this afternoon, Nicole Boschi, Director of Regulatory Affairs at the National Multiple Sclerosis Society, Tish Mochigemba, Associate Professor in the Health Outcomes Division at the University of Texas College of Pharmacy, Stacy Cole, Principal Researcher in Genentech's Health Policy and Systems Research Team, and Daniel Touchette, Professor in the Department of Pharmacy Systems, Outcomes, and Policy at the University of Illinois, Chicago. I will now invite Dr. Boschi to offer her introductory remarks.
Thank you so much, Ebere. Can you hear me? Thank you so much, Ebere. Thank you so much to IVI. I think this has been an extremely valuable experience, both in the roundtables that were conducted this fall/winter, and also convening everyone in the same room to really hash out these issues. So I'll start by saying that it's critical that researchers speak with patients at the beginning of any study in the design phase. And I love that Jennifer gave the example of the depression study when talking to patients, it really changed what was studied when patients articulated what mattered to them. For example, in the MS space, does cognition matter to you? Does mobility matter to you? Does all the above? So I think it's really critical that this is done early. These discussions happen often. And I think it's also really important that this outreach is done with cultural sensitivity and in a patient's preferred language. With people that look like them, with people that they trust. Oftentimes, people in the multiple sclerosis space, when they're first diagnosed, they may not be familiar with the healthcare system. They may not even be seeing an MS specialist at first. So it's really important that those who aren't familiar with the healthcare system have things explained to them in a language that they can understand, both absent of any jargon and in their preferred actual language, whether that be English, Spanish, French, et cetera, et cetera. We also must empower patients to provide data and feedback. I really liked Dr. Hughes's example of Patients didn't know what they were talking about. When you're using these terms and jargon, patients don't understand that. That's not in their everyday vernacular. That's not in their everyday life. So it's really important to take a step back and ask, are these patients that I'm interviewing, are they ready to provide the feedback that is essential for me to move forward with my study? Or do I need to check myself and back up and have a level setting moment? Also, speaking with patient advocacy groups, for example, the National Multiple Sclerosis Society, that's really important. But I don't have MS. I can tell you what people who live with MS have told me, but then we're just playing a game of telephone. So you need to actually speak with the patients themselves. And if you've met one person with MS, you've met one person. So our methods need to accommodate, and we need to figure out what to do statistically to represent this range of different perspectives and different opinions. If we can send someone to the moon, we can figure out the statistics and we can figure out the math of how to do this. And finally, I'll add that the focus on equity in HTA methods can't just be an academic exercise. We can't have these conversations in our ivory towers and not implement any of them. This needs to be put into real world practice, and additional learnings from these studies need to be disseminated to the broader community so that we can have discussions like we're having today of how to move this field forward, instead of just sitting in rooms with a view of the Washington Monument, talking about how we're going to do health equity. We need to actually sit down and do it. So with that, I'll pass it along.
Thank you, Nicole. So I want to echo what Nicole said about the opportunity to be involved in the IVI initiative. I also had the opportunity to participate in the roundtables, and I think it's very inspiring to me as a researcher. And that's the hat I'm sitting at this table on today. So I'm going to share with you a little bit about my experience as a community engaged researcher. And because I'm a community engaged researcher, I really believe in authentically engaging the communities that I work with. And part of that, one approach that has really worked for me is what's described in the literature as this cycle of trust in the community engaged research. And that means really engaging the community before, after, and during the study. So the tricky part to this is that the engagement before does not necessarily follow the traditional timeline that we might expect in research, that, it can take time to cultivate and to grow. And but yet, if you don't do that in a meaningful and what I think authentic way, it can actually sort of shatter the foundation of trust in the community you're trying to reach before even really getting started. And so what this is that before part is really, it's getting to know each other, right? So you are getting to know things about the community that you may be working with. In my case, I work with people experiencing homelessness, but I need to understand, their culture, what's important to them, where do we have rapport? Are there areas that make sense for us to align with, to work on? All of those are just essential for that before part. And sometimes that can't be rushed either, because then that does result in that inauthenticity, which can actually be more harmful than good in communities. The other thing that I think is really important as a researcher, and this would be throughout this cycle of trust, is that we always have to be checking our assumptions or biases. So one thing that researchers may do really well is they delve into the literature, they might have assumptions or some ideas about where gaps may be occurring. And so that's important. We can sort of keep that in the back of our mind, but sometimes none of that connects with your community of interest. Sometimes what the real issues are, they're not in the literature yet. They haven't really had enough traction to get there. So we have to really we have to keep that in mind, right? But at the same time, we can't allow that to blind us to what people are telling us. And so I think that's a constant. I think even the more you get into, for instance, I've been doing work with people experiencing homelessness for 14 years. I feel like it's more important now for me to check my assumptions and biases than it was before, because you can kind of get into your routine where okay, I know how this works. But no, you constantly have to be doing that. So I think that's really important as researchers for us to do that. The other piece of it is that, we're at a time where health equity we see that term everywhere. And we could even say it's kind of a buzzword. Oh, okay, we have to address health equity, right? Again, we have to be careful about the way we're approaching communities. And I think if you are having communities come to the table, patients, they have to see that their feedback is informing action. And if you don't see that, why would they keep coming to the table? So with that, I will turn it over to Stacy.
All right. I'm going to echo the thanks that I heard from Tish and Nicole. I think we're all going to thank IVI, but I just want to say there's been a really thoughtful approach to understanding this really complex and important issue. And I absolutely agree with everything that's been said about the patient engagement angle. I am the math person, but I promise I'm not going to talk about too much math and there won't be a quiz. But I am going to approach this from my own background. So I'm very fortunate to work at Genentech in a role where my job is to test new methods for value assessment. But I also have this amazing opportunity to serve as the chair of a special interest group for the International Society for Pharmacoeconomics and Outcomes Research, ISPOR. But what this group does is we're trying to just pull together what's happening from a methods and data angle around health equity for health economics and outcomes research. So with that background in mind, I did want to make a couple of points of where I think some of the math is and what I would recommend individuals consider as you're starting to approach this. So number one, I would say is progress is happening around all of us right now. I think it's really easy to worry or think the glass is half full and say, it's going to take 30 years before we can get there. So for example, we record over 36 racial and ethnic categories in death data, and that doesn't cover everybody. I'm a modeler. I need something called a life table to build a model. I can get that for 3 racial and ethnic categories. That is how big the gaps are. But there are individuals starting to fill gaps in small ways all around the world. For example, there's a method called distributional cost effectiveness analysis or equity informative cost effectiveness analysis. And this is being used all over the world to try to add more data and information about beyond average patient effects into health technology assessment. It's happening in Chile, Thailand, Brazil, the United States, the United Kingdom. With that in mind, the next thing that I would say is don't let perfection stand in the way of progress. It's going to take all of us years of hard work to get there, but we can all start making really small steps today to make a better decision. So I'm a modeler. I adopted distributional cost effectiveness analysis in my own work, but I didn't have to learn all those methods. When I go out and I gather data for an economic model, why don't I also gather data on, does this disease present differently across racial and ethnic groups? Does it have a different presentation based on where you live or how vulnerable you are? What are the differences in the timing of diagnosis, the stage of diagnosis, the level of access? Do I know if this disease impacts someone differently based on a food desert or where they live? Even if I don't put that into a model, if I actually just synthesize that information and say, this is what we know, what we don't know, I've taken so many steps forward. Now I'm going to talk a little bit about math, but why do I love modeling? I can put thousands of pieces of data together to answer questions I couldn't answer before. And then I can say, is this an answer that I know really well, or is there a lot of uncertainty? But more importantly, I can take a litany of issues and say, if I were to fill these data gaps, which is going to help me understand how to make a better decision? So we talk about prioritizing. If I go and I try these methods, I can say, all right, in Alzheimer's disease, considering the policies that are happening, what are the next 3 things we need to fill to really understand what it's going to mean if we make a decision for vulnerable communities? And I do want to make the point that the data is going to be really bad. And so there's a really important need to look beyond a peer-reviewed literature or a meta-analysis to talk to patients and to really be able to take this anecdotal evidence and start to work with it, even if there's some uncertainty around it. And the last point that I want to make, and I love the fact that Dr. Hughes said this, is be intentional. So I have been an economic modeler for now 17 years. And even though I carried around some papers from Richard Cookson and James Loveco for like 5 years, I didn't really start learning these methods myself until 3.5 years ago. And I just asked questions. I'm doing an observational study. Well, do I consider race and ethnicity? Is that a good measure? How do you look at geographic effects? And if we start to simply open up a journal or look at a white paper, we're going to ask a more informed question the next time. So I'm a pretty glass half full kind of person, but what I'd like to say is there's a mountain of work to be done, but if all of us keep doing what we're doing, we're going to make better decisions tomorrow, and I think we're already on the road there. I'm going to pass it along to Dan.
Right, thank you, Stacy. So I am also a health economist, and I'm a perfect example of how we need better training in this area. And so I was asked to address somewhat some of the needs that we have to train better researchers in this area. And in preparing for this discussion panel, I started with trying to determine what health equity or how health equity is defined and how HTA could impact and influence inequities. And I have some practical experience with doing all of this. I've done some modeling for the Institute for Clinical and Economic Review, and I've had about 25, 30 years of doing this type of doing health economics research. But I just wanted to start at the beginning and think through and how we could possibly do some of this. And so it's health equities, especially around HTA, has been primarily described using three main concepts. The first is achieving the highest level of health for all people, which we heard earlier today. CMS adopted that definition. It's also about opportunity. That is, everybody has an equal opportunity to achieve good health. That's a different way that it's sometimes framed. And another way is the absence of disparities, described as an absence of unfair and unavoidable or remediable differences in health. In measuring health equity, there have been many different approaches. Clearly, health equity is multidimensional. I think we can all agree on that. But how it's measured and how it's assessed is dependent on the purpose of the measurement and the availability of that data. For example, the National Equity Atlas has 5 domains. Those are demographics, economic vitality, readiness, connectedness, and economic benefits. The Neighborhood Atlas Area Deprivation Index covers income, education, employment, and housing equity. And you can see all of these are very different dimensions. People are measuring these in different ways. I reviewed a recent distributional cost effectiveness analysis, a DCEA, of a hypothetical COVID treatment conducted from a Medicare perspective, which included race and a disparities index called the Social Vulnerabilities Index, which is included and collected at the US Census Tract level to estimate the resilience of communities during times of public health emergencies, another approach to measuring health disparities. Patient interviews that were conducted while I was working on economic analyses with ICER highlighted a number of disparities for which ethnicity, race, gender, sexual orientation, income, wealth, and other categorizations and proxies for where potential disparities exist might poorly characterize the disparities themselves. In addition, intersectionality is an important term that I haven't heard yet today. And that's where there are the presence of 2 or more disparities. And the results of having intersectionality may not be additive or multiplicative. Getting back to the math, we don't know how these interact and what impact they have. All of these are important when we're dealing with the math, with trying to develop models. And I'm talking about decision models now. We've heard models a few different ways today. So the models that CMS are describing are models of care. These are mathematical, these decision models are mathematical models. Trying to incorporate these complex processes in health technology assessment will require considerably more empirical research. It will also require researchers with a broad range of both qualitative and quantitative research skills, as we've heard. Most of the work done to date incorporating the concept of health disparities into HTA has been done from a single national payer's perspective. Improving health disparities, sometimes in opposition to maximizing profits in a for-profit healthcare marketplace. Much more work is needed, not just in validating and translating concepts and approaches to a complex multi-payer and disjointed health and insurance system such as exists in the US. It will also require training of those who would consider using the results of these analyses and use them in an appropriate and ethical manner. Furthermore, current policies implemented by a capitalistic approach to healthcare and health insurance have themselves led directly to health disparities that cannot be overcome by health technology assessment alone. Current issues with health technology assessment that need to be addressed to be better positioned to evaluate the impact of new therapies on health disparities include that HTA typically measures the average value of innovations, as we've heard earlier today. However, the value of innovations varies among different populations and even among individuals. Available data used in assessing whether new technologies impact health disparities is often missing, and where present is likely to be biased due to limitations in the manner in and the reasons for which it was collected. Researchers are using what is available and not what is best, although not much different from the practice of using unvalidated claims data for research purposes, where we're using administrative data for a very different purpose. Results of health technology assessment are often needed early in a new technology's availability, where there may be limited data available on its impact to subgroups with health disparities. This is something I've come across quite often working with ICER. There's usually no real-world information available at the time a drug comes to market, and the only organization or only group that have been responsible for generating this data is the pharmaceutical company who is bringing the product to market if we're talking about a drug. Some innovations that provide value may also increase health disparities. This is especially true for high impact, high cost therapies, which may not become readily available to those with lower income or wealth. Those high costs are passed on through from the pharmaceutical manufacturer or other manufacturer to the insurance company, who then passes it on, trying to restrict the use of these medications or treatments. So patients have higher copays and the like. So other approaches that have been suggested, things like lowering the thresholds, the cost effectiveness thresholds for drugs, may predominantly benefit those with health disparities, or that benefit those with health disparities may result in a disincentive to develop such drugs. So we can't take that type of an approach as well. We want these drugs to be developed. We also want them to be used. We need a set of guidelines for the ethical use of HTA in policy decisions. So just in wrapping up, given the political, ethical, complex behavioral and medical aspects of research involving the intersection of health disparities and health technology assessments, it's critical to have a well-trained scientific workforce in academia and in research, and in the manufacturing industry, in the insurance industry, and government to help push the envelope. This workforce will need training in, or at the very least, exposure to qualitative and quantitative research methodologies, something that I've had to learn on the fly. I've trained in quantitative research methods, became familiar with qualitative research methods only because I'm working in academia and working with others who employ those methods. Ideally, this workforce will also be diverse, drawing from those populations who are most likely to be affected by and who may be trusted by those with health disparities. We need regional centers of excellence who specialize in the multidisciplinary training of individuals better equipped to tackle these complex problems. We also need people who are willing to train in rural environments and not just urban environments, because health disparities in the rural setting are very different from health disparities in urban settings. So we can't forget that there are different sources of disparities, and we need to address those disparities where they are. And that's my opening statement.
Thank you very much to all of you for these thoughtful opening remarks. There's a lot there to unpack. We will try to do our best in the 20 or so minutes that we have, and then certainly looking forward to those questions. So again, if you're online, please go ahead and just feel free at any time to add those questions through the Q&A feature in the Zoom room. I have some questions that I might just offer to you all on the panel. I might start, Nicole, with you and Tish. We've talked a bit about patient engagement. You made the point early on about how it is important to be authentic early and often, if you will. So as we think about our methods that we have available to us and the importance of engaging with our communities early in the process, how can researchers balance the diversity of the patient experience? Nicole, you did make a reference to that, and preferences through the engagement work. What are some best practices that you've seen in the past, or other statements you can make around that?
So I will piggyback on what Daniel just said. We really need to think about our scientific workforce because people with chronic diseases and those of the minority or marginalized communities, they're most comfortable, like anyone would be, having a conversation with someone that they trust. Many people with MS, I think I alluded to this before, they don't have a good relationship with the healthcare system. And many of them may not even see an MS specialist, and may just be seeing their primary care or general neurologist. So to decrease their anxiety, you need to meet people where they're at. Maybe work with the community physicians, maybe work with the community neurologists, because that's where these people are receiving their care and that's who they feel most comfortable sharing their inner thoughts and struggles with. And I will again echo Daniel's point. We really need to think differently about patient engagement and ensure diverse investigators, and how this information is shared. The MS Society underscores the importance of diversity in the healthcare workforce, and this includes physicians, researchers, nurses, anyone that the patient comes in contact with, including clinical trial recruiters. And I'll leave it at that.
Yes, Tish, interested in your thoughts?
Yes, thank you, Nicole. And Nicole ended on clinical trial recruiters, and it made me think of something as well. So meeting people where they are. And so we do have to think about where do we reach people who may have not traditionally been reached to even have the opportunity to participate in research. And so, for example, in my work with people experiencing homelessness, we recruit in the community at faith-based organizations rather than under the traditional healthcare system. And our team, my team, the field team, they see our study participants even when it's not a study visit. They're truly part of the community. That builds trust, it builds rapport, all of those things. I think for myself, with thinking about best practices, and we've the earlier panel specifically, Karen talked about accountability. Transparency has come up. So I think that we have a responsibility as researchers to document how the patient voice is actually integrated with the methods, beginning with the research question, development of the intervention, all of those things. We can document at which places the patient voice impacted the way the study was designed. I also think as a best practice that when we say partners, what does that really mean, right? So that means that the patients or community members, they are co-investigators or possibly even co-PIs where that's appropriate. That's really helping with that power issue that has come up so many times. Also incentives and resources. So anytime a patient participates, they have to be compensated for their time. And I think that's something that's really important. And all researchers really need to think about. Whoever's contributing needs to be compensated. And the same, we think about research and grants, the way some of those research grants are, the funding for that should be equitably distributed as well. Not only the university, but the partners that are around the table, do they have the appropriate allocation of the funding? I think that's something that's really important as well. Nicole has said this, but I also want to reiterate it. I think it's a best practice where you have to share results back to the communities that you're working with. And that would be, in a forum in the community, in a way that can be understood in plain language, all of those things. So for me, those are some of the best practices that come to mind.
Thank you very much. And already giving us some practical ideas for incorporating hopefully into your own projects. I love what Tish had mentioned about the dynamic qualities to all of this. So as a researcher, you may be in this for a decade, 2 decades, but you're also growing and you're understanding the importance of that self-reflection. The methodological implications to that. So my next question goes to Stacy and Dan, where we can think about the methods that are available to assess health technologies and how they impact health disparities. Can you talk about a current method or methodological concern that we face in this work? And when you're doing so, I might invite you to also think about something that Dan had mentioned, which is workforce development.
Thank you for the easy question. I'm going to actually just talk about, I think, data challenges, but I'm trying to do it in a really concrete way. In the United States, we know there are disparities, right? We have study after study. We have never actually mapped disparities for the US population based on how you identify, whether it's race, ethnicity, socioeconomic status, or even geography. With those things combined, I cannot tell you differences in longevity, disability, or quality of life. So I think this point was made earlier by Dr. Hughes. If we want to think about measuring all these impacts, we have to have a baseline, and other countries have done that. The reason we haven't done that here is pretty challenging. So number one is we have a lot of suppression of information. So if I wanted to say, I'm going to look at every US county and tell you outcomes, anytime I'm looking at these smaller cell counts for mortality or outcomes, it's suppressed. So we tried to map inequality for the US using readily available data through an amazing resource called County Health Rankings, which aggregates all this great data. But if we hadn't tried to kind of pull in those outliers that were suppressed, we would have represented less than half the disparity. So number one is we're not necessarily having access to the data we need. And then I think there's this underlying current of we don't have some of that data. So whether or not you like quality adjusted life expectancy, if you wanted to do some of these studies to say what is baseline health, we actually haven't collected information for the general public for quality adjusted life expectancy since 2002. So I think there's work happening, but how are we going to measure progress, or how are we going to model an effect if we don't know where we're starting? I'm going to plug one more thing that I'm not going to open up a whole can of worms, but we can't talk about equity without opportunity costs. So even if there's this amazing new intervention that saves someone from blindness, where's that money coming from? And especially if we're talking to a state. So whenever I've been on panels or I've talked to someone who maybe represents a state, they say, that's great. What am I going to do? Am I going to take away money for food stamps? And so we need much better data on how providers and health systems spend their money to really think about opportunity costs. It's not just who's going to get a bigger impact or different impact, but who's going to face the burden of those resources foregone. So your easy question had a second easy part, which was workforce development. I think I was trained in health economics and outcomes research, and like claims and electronic health records were king, and I don't think they are. I think that's the wrong data. So I would say some of the things that I would want to encourage, number one is educating people on the right data for the right methods, more robust use and introduction to US panel data and survey data. And I'm going to go a little nerdy. I think more training around imputation. So this is the way that we deal with missing data, and our data is going to be crap for a while, right? Garbage in, garbage out. So how do we have like the best worst case scenario? And I think that there are going to have to be some methods that we apply to understand how we impute data we don't have and understand the implications of that.
Right, and I'm going to go in a slightly different direction. I'm going to talk about two experiences that I've had working with ICER and with other colleagues around patient-reported outcomes. The first is I was involved in an assessment looking at new treatments for myasthenia gravis. And ICER has a pretty interesting approach in that we do a lot of work up front talking with patient groups, with manufacturers, with clinicians and others. And in discussions with the patient groups, we heard that myasthenia gravis affects Black women at a younger age, typically than the general myasthenia gravis population. And it affects these women at an age where they may be in their childbirthing years. And so they put off having a family, and there's a lot of other factors, I guess, or a lot of other considerations that might go into trying to put value or numbers on a treatment that impacts things for this age group. We heard this from the patient group, but I just want to point out where we're missing data. We're not just missing data, we're missing analyses, we're missing, there isn't a lot of funding that goes to this type of research. And so we left those discussions feeling, there should be evidence of this somewhere. We need a number. We need to know how this group is particularly affected, and we don't. went into the literature, and there was not a single publication that we were able to identify documenting this claim. And so we were left in the end not really being able to consider this in our mathematical calculation of anything because of the timeline and the funding that's available. This was too late in the process to be part of our deliberations. Had this been identified 4 years earlier as an important consideration, there may have been an opportunity to have researchers do some type of an evaluation to try and quantify some of these. And that's just to highlight where there's gaps in the evidence. There's gaps in the evidence absolutely everywhere. And so this is a problem that's going to take a large workforce. It's going to take funds. It's going to take initiative to address some of these gaps. And importantly, they need to be addressed at the right point in the timeline to be part of policy decisions. It's difficult to change policies after they've been implemented. So it needs to be at the time when new policies are being considered, the coverage of these drugs as an example. And then the other thing is that we do have great models already available to us where this type of work has been done. What we're really talking about is taking into consideration individual preferences and individual values. And so, just to highlight one example, in cancer care, the use of patient-reported outcomes in cancer care, there's a lot of work that's being done to identify patient preferences for certain types of side effects or certain aspects of medications that might make a particular medication more preferable to somebody. An example might be a cancer drug that has sexual side effects. For a 70-year-old, that may have a much lower impact on their quality of life than it might for a 20-year-old or 25-year-old looking to start a family. And we've developed a number of these types of patient-reported outcome tools that can help with selection of treatments. We can take these same types of approaches and adapt them to health technology assessment, identifying what's important to people, identifying determining how to quantify these, and then build them into our mathematical models that require these types of estimates. So I'm going to leave it there, but we need the right type of people to be able to do these.
Absolutely. You need the workforce for that. Thank you, Dan, for those comments. I might actually stay with you for our closing thoughts, and then we'll go right back down the panel this way. So a lot of really important points having been raised here about methods, about thinking about ourselves as researchers in context and in relation to the community. Just asking for one thought from each person. So a first step. What is the first step that you would say researchers can take today or before their next meeting to start to better embed equity considerations into our HTA methods?
You want me to start?
Yes, and then we can work
All
our
right.
way back.
Yes, I was thinking about that. I thought I was going to be asked this question. I've been thinking about it. So we need incentives to be better aligned. I'm going to take the conversation away from the researchers themselves and put it more on the funding organizations. Because as we saw with PCORI, when PCORI first came out, people were complaining, oh, I have to incorporate patients into developing my methods. And I heard a lot of complaints from researchers, especially researchers who don't work with patients as much. They work with large data sets or things like that. And now they have to start considering the patient perspective more. But either through self-selection or through adaptation, these researchers have adapted. They've become successful. And in academia, it's publish or perish. You have to bring in grants and you have to publish your findings. And if the granting organizations are requiring patient-centeredness as part of the approach, researchers adapt, and they adapt quickly. Within a very small amount of time, all the complaints went away. People learned how to build this into their processes, and it became part of the norm. And NIH has started to adopt more patient-centered approaches as well. So if we could just have these aligned well, I think we could really make a difference.
Wonderful, thank you. Stacy, Tish, and then Nicole, if you all could name one step, and then we'll head right into our audience Q&A.
Yeah, I would recommend that researchers become more familiar with deprivation measures. Just like Dr. Hughes mentioned, the area deprivation index, the social vulnerability index. Until our data is better, these are going to be the stepping stones that we have to use, not only to study disease outcomes, but if we want to think about the whole patient and what their disease means for their whole life and their health outcomes, I think those are our best next step.
Okay, thank you. Tish?
Yeah, so I think as researchers, we need to challenge the status quo, right? So there's just been things we've done a certain way, for whatever reason. And so I think that we need to be intentional from the very beginning of a study to say, okay, where are gaps? Where are patients or groups that may not be included? Is there a way for us to include them? But then also, if they're not, how does that impact the findings and how you interpret them? So we can all call that out in a discussion of a paper or whatever it may be. However you're presenting your results, that can be called out. And then importantly, I know in our own graduate program, we are really challenging our students who are the future researchers to identify those issues and just call them out, right? And say, this was missing in the study, this is the gap. This may be how we can address it better in the future.
Thank you. Nicole, you can close us out.
I'll add that researchers really need to get better at using lay language around patients. You can't just have a patient be the token patient on a panel like this and talk in jargon and expect that patient to feel welcomed and expect that patient to feel like they can share their thoughts. Also, I'll add that you need to educate patients on how their data is going to be used. I think patients want to be helpful. They want to help the next person that's going to be diagnosed behind them. But in order to provide information that's going to be useful, patients need to know where this is going, how their data is going to be used, and what are you hoping to get out of it.
Thank you. Thank you very much for these thoughts on these questions. And then we'll see what maybe our in-person audience, what questions you all might have, or our online audience. Yes, over here. Yeah, a mic is coming around for you.
Great. I was going to speak from the diaphragm. Thank you so much for this insightful discussion. So I'm Ashley Valentine. I come from Sick Cells. We're a sickle cell disease advocacy nonprofit. And so this is really relevant to the community that we serve. And some items that really stuck with me is this idea of, the data gaps, because just a lot of the data doesn't exist. And so when we think about groups like ICER or HTA assessments, when we were going through the ICER reviews, just the data was not there, but that didn't mean that it wasn't happening. So I'm curious about your thoughts for populations like this. So we missed the timing because the data wasn't there. The economic model couldn't include a lot of the gaps that we were highlighting because the data wasn't there. And then the end result now are across the board utilization controls that harm patients. So my question here is, while we are working to get the data to make it exist, what do we do in the meantime as we're identifying these disparities?
I'll go. And I've never done an ICER model, so I'm going to answer it from my perspective. I think that we should be taking information that might look a little bit different. So surveying patient groups, taking anecdotal evidence. And I think we should still be putting it in with a caveat to an economic model. Because how would we know the importance of filling that gap in the future? How would we know whether something that we know might be important actually changes a patient's outcomes, a patient's cost, or health equities? So I'm a big fan of, there's information that we know that's best practice and we kind of have gold standard evidence, but we can't ignore the things we know anecdotally. So I'm a large fan of asking these questions early, even if they're based on talking to 15 patients or 5 patient groups, and then determining, how do we prioritize the data that we do need to gather?
Right, and I'll add to that. So as a person who's done decision modeling, done a lot of it, we can have one of the strengths of decision analysis is that you can incorporate uncertainty and you can look at different types of situations, different scenarios. And so you absolutely can address it in that way. The only concern, well, not really concern, the issue with with doing this is that payers don't care. They're not gonna use that information in making their determinations. The way ICER has addressed this, and I don't want to speak for ICER because I'm not an employee of ICER, but the way they have addressed this is put it into other. They put it as language in their other concerns or other contextual considerations section, so that those who have an interest can look at this and determine whether or not it matters to them. The difficulty is that not putting it into the model means that the prices, which is usually what we're trying to determine, what's a fair price for a drug or what's a value-based price, it doesn't impact those prices, and we don't know how much it should affect them. So we can address that in some ways with modeling. But I think we need better training of individuals who end up in the insurance industry and in the pharmaceutical manufacturers group who can address these ethical issues and in an ethical and relevant way.
We have a question up front. Oh, first, you can go first and then we'll come to Jennifer.
Like Nicole, that you were talking about the circle of trust, before, during, and after. And I think all of the panel has really spoke to that. But one thing that I'm curious about, is there any best practice that you can highlight relative to the going back to the communities and sharing information thereafter?
So unfortunately, I don't have specific examples of that, but we just had an event last week where we brought in 200 people who are living with MS to DC. And every person in that room wants to be useful, wants to share their experiences with trusted parties. And I think every single one of them wants to know at the end of the day, what did we contribute? Were we helpful? How are we helpful? So I think it's so important, whether it's going back to a patient group, whether it's back to going back to a community health center. I mean, there's a bunch of different ideas on how we can do this. And I don't think any one idea is right. I think we just need to do it.
Great points. The importance of action. Tish, I'll have you make one comment and then we'll go to the person right next to our recent question.
I wanted to mention, so that's something that going back to the community is something that my team is really working on. And we very soon will be working with our community advisory board for them to tell us how to come back to the community and share the results. So, we might think, oh, we can make this little cute infographic or this, and maybe that's not what it's going to be. So we're going to actually partner with our advisory board to sort of figure that out and what that might look like.
Great.
Hopefully there are patients on the advisory board who can tell you how they want their data to come back to them.
Exactly. So we do have time for one more question and we'll take it here. Thank you.
Right, we have a question from online, and this question is coming from Andrew Masali from Alexion. The question is, are there some policy implications when thinking about distributional cost effectiveness analysis? Are there concerns that, innovations may be less accessible? They might have less favorable results in any health technology assessment. Difficult for certain populations to access. So are there any concerns around distributional cost effectiveness analysis?
Yes. So what I would say is all you're doing is you're creating some new data points. So you're not actually talking about pricing. You're going to say what types of populations have a larger or a smaller effective treatment, what types of populations may have different costs, and what types of populations are going to likely bear the opportunity cost. And then you consider kind of where all of our health starts. So you're right, there could be, for only people that earn, this is crazy, only people that are doctors, you can cure blindness. Well, if you did a distributional cost effectiveness analysis, it would say that's going to have negative equity effects. And I think it's all going to come down to we need to be much better at understanding those equity effects so they're part of a broader decision. And the other point I want to make is it's not a treatment, it is access to a treatment, right? And so I actually think distributional cost effectiveness analysis considers more policy relevant questions. What does it mean if this population gets access to a drug 3 years earlier? What does it mean if this population has a prevalence 2 times higher? And so I think it's answering new questions, but you're right, it might pose some hard trade-offs that someone wants to make between efficiency, which is maybe getting a lot more health gains overall for a population, and equity. So it probably is going to raise some contentious discussions that need to be had.
Thank you very much. Thank you for the questions that have been posed both in person and online. We've heard a lot today about the importance of thinking about one person at a time, subgroups at a time, contextualized subgroups at a time, implications for methods, data. So we hope you've gotten some practical ideas, which was our goal, to take to your next meeting. And we look forward to you all joining us in advancing this work. I want to thank the panel for your expertise and for your time this afternoon.
That's a great, yeah.
Join me in thanking Barry as an excellent moderator of the panel discussion. We now have a break until 2 o'clock Eastern. Thank you.